associates, my colleagues and friends, my postgraduates, good afternoon to everyone. It is nice to connect you once again through this platform as Chairperson, Oncology Committee of OXI. From Oncology Committee, Dr. Vasnamani, Dr. Deepa Tangamani and myself, we like to express our sincere gratitude to our President, Dr. Jairani Kamraj, and to our Honorary Secretary, Dr. Kundevi Shankar, for giving this opportunity to host our first webinar series on cancer endometrium. It's a masterclass. And I welcome you all for this gathering. I request Kundevi ma'am, Dr. Kundevi Shankar, Honorary Secretary, to render the Oxy prayer and take on the proceedings.
Thank you, ma'am. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Next slide, please. Next slide, I have to talk about, I have to introduce Jairani ma'am, Kundevi ma'am formally. Dr. Jairani Kamraj ma'am, everybody knows her as a very efficient, enthusiastic, very energetic President OXI for this year 2023. She's a senior consultant of reproductive medicine at Akash OTD Center. She's a member of organizing team for SR 2015 as organizing secretary, member of board of studies for MJ Medical University, lifetime member of FOXI and ASRM.
Ma'am, we'll go ahead, ma'am. We'll go ahead, not a problem.
Kundevi is a renowned national board certified obstetric and gynecologist. She heads a prestigious reproductive medicine institute at MMM, and I'm proud to say she was my from the same alma mater, KMC, and also she was our associate with Ramchandra for a long time. And I thank both of you for giving us this oncology committee a chance to host our webinar on endometrial CA. Next slide, please. Next slide, please.
Ma'am, Tamil Thai Valta and light.
Okay. Slide la da.
Hello. அதான் ஜாயின் பண்ணிட்டேன். நான் என்னோட வீடியோ
Next slide, please. I'm privileged to introduce the chairpersons for the first session, Dr. Vasudha Mani. She had been associated with the Oxy for a long time, and she had become busy later by becoming the ADME and Secretary Selection Committee, Dean of Kilpatrick Medical College and Villupuram Medical College. I have seen her how efficiently she conducted the meetings, alumni meetings at Kilpatrick Medical College as being as I've attended some of those meetings. She was ex-superintendent of GICT RSRM Hospital, awarded Best Doctor Award from Government of Tamil Nadu in 2018. She continues to serve our society through as Dean Indira Medical College. Nice to have you, ma'am. Dr. Sumati C. She had been associated with our Oxy for quite some time, and she had been our co-opted member last year. And she had put in quite a lot of years in government service, as high as 30 years, and she had got 25 years of experience in the field of OG. She has been a UG and PG teacher for more than 20 years, master trainer in emergency obstetrics and specially trained in colposcopy. Areas of interest are cancer screening and social obstetrics. Over to you.
Ma'am, presidential address, ma'am. Ma'am, Jairani madam, presidential address.
Next slide, poda solra. That slide, she's cutting it off. Please put the next slide.
Akiti, previous slides, Akiti.
Yeah. Now I invite our president, Oxy, to give a presidential address for this webinar.
Madam, let's start with the Oxy prayer. May I ask my Honorary Secretary, Dr. Kundavi, to give the Oxy prayer and then let me follow with an address. Kundavi, over to you for your Oxy prayer.
I've just finished the prayer.
Finish the prayer.
Mudishtanga, madam.
It was before, madam.
Oh, I'm sorry. I didn't know that. So, respected chairperson of Oncology Committee of Oxy, our co-chairs Deepa and Dr. Vasudha Mani, and the senior faculties of this webinar, Dr. Sumati, Dr. Padma, Dr. Hepzibah Madam, Dr. Gopinath Sir, Dr. Madhupriya and Dr. Rajiv, and all my Oxy team, as well as all the delegates, a very special afternoon wishes to one and all. It's a great pleasure to be here because we know this endometrial cancer is really a important aspect in the gynec oncology that we all should know. And every time when we see, we read a lot, we hear a lot, we talk a lot, but still we have a lot of new things coming up, and we have to update our knowledge in the in the endometrial, especially in oncology, which is all a real upcoming ones. And we have a lot of thinking on the ongoing fertility preservation in women with endometrial cancer, which is a very important step that is coming out in the latest way. So in this way, I really appreciate my oncology committee for setting up this master class to start on the endometrial cancer, which is a very important gynec cancer from the women's point of view, especially in the fertility and the gynecology. So it's a real great pleasure to have this topic as a webinar for all the gynecologists, practitioners all over the country. And I'm very happy, and I congratulate the Oncology Committee of Oxy for taking up this topic for this webinar. And I wish all the best. And I'll definitely, it's a real good knowledge sharing from the senior experts who are here, who can share a lot of insights and all the knowledge and experiences what they have in the field of the endometrial cancer and gynec oncology. And I wish the best of luck for all the committee members. And I thank Shield for sponsoring this platform to give Oxy a very good spreading of knowledge through your platform. Thank you, one and all, and over to the chairpersons to start the first session.
Somebody, madam, you can start the introduction of the speakers, ma'am.
Yes, ma'am.
Good
afternoon. I invite Dr. Sumati to introduce the first speaker.
Yes. Good afternoon, ma'am. Good afternoon to everyone here. I'm very happy to introduce Dr. S. Fatma. She's a master's, done a master's and DNB in OBG. She's done a fellowship in Gynec Oncology, Netherlands. She's a senior consultant and HOD, Department of OBG and Meenakshi Mission Hospital, Madurai.
Ma'am, can you see my screen?
Not yet, ma'am.
Not yet, ma'am.
Ma'am, if your signal is strong, you can put on your video also, ma'am.
Video isn't starting here.
The signal is weak, so cut off your own video. You can just play on the slides alone. People will have a better impact.
Is it seen now?
Yeah, but they are not able to see.
Yes, ma'am. Can you make it full screen, ma'am?
Yeah. Is it okay?
Yes, ma'am.
Yeah. At the outset, I would like to thank the Oxy for this opportunity, and thanks Deepa for coordinating and then taking forward the meeting, and thank the chairpersons for the kind introduction. And coming for today's topic, it's quite interesting and it's quite close to my heart, endometrial cancer. And today we'll see what are the red flag symptoms of it. So in recent days, endometrial cancer is emerging to be the most common of all the gynecological cancers. Maybe 20-25 years earlier, we would have said it as cancer cervix. But now we are seeing more and more women coming up with endometrial cancers rather than cervical cancers. And the lifetime risk of getting an endometrial cancer is around 2 to 3%. But the beauty of the endometrial cancer is it presents quite early. Nearly 90% of the women with an endometrial cancer, they present with an abnormal uterine bleeding, and nearly 75% of them get detected in the stage 1 itself, and they have a good prognosis, provided the caregiver picks up the lesion in the early stage and treats. So the diagnostic motto of endometrial cancer management is to seek and treat. While the vast majority, as I said, are symptomatic. They present with symptoms quite early, like a postmenopausal bleeding, or those women who have a high risk for developing endometrial hyperplasia, like those with hypergenic states, or those who are on HRT, those who are on drugs like tamoxifen. These women, when they present with bleeding, then we have to go in early, diagnose, and then treat them. But however, there are some of the women in whom the lesion gets picked up while they are asymptomatic, especially when they come for a master health checkup or something like that. They have an ultrasound done, and then we see a thick endometrium. And should we investigate these women? So that will be the crux of my talk today. So unlike CS cervix, which has a clear-cut pre-malignant lesion, when it comes to endometrial cancer, we do not have a pre-malignant condition, though we talk about endometrial intraepithelial neoplasia. Most of the times, as once again insisted, the patient presents early, and it is up to us to take up these women and investigate them early and see whether they are having a lingering malignancy there. So the importance as far as endometrial cancer goes is early diagnostic in the symptomatic stage. So when the disease gets picked up earlier, then the treatment is easier, and the prognosis is good in the long run. So classically, we have been said that the endometrial cancer has these typical risk factors. That is the corpus cancer syndrome, obesity, hypertension, and diabetes. And these form the mechanism for the metabolic disturbances, mainly which involves the insulin pathway, insulin resistance and hyperinsulinemia, with its associated increase in the insulin-like growth factors activation and other inflammatory markers activation, plus the associated endometrial hypersecretion, which all leads to malignancy. A similar state is seen in patients who present for infertility evaluation, especially those with PCOS. They also have a similar kind of a metabolic problem there, and they are more prone, we all know, they are more prone for endometrial hyperplasia and cancers. So in this, what happens is, because there is a chronic anovulation and or oligo-ovulation, there is a hypersecretion of estrogen, and the opposing action of progesterone is not there. And this prolonged unopposed estrogen exposure is the one which leads on to the disease. Well, that is for the women who have a hyperestrogenic state. There are a second group of women in whom the major risk factor is the age per se. And now we see more women crossing 60, and women easily live up to 80, 85. So age becomes a very important risk factor in this group of women who are having a type 2 endometrial cancer. This typically occurs in a patient who is having a normal BMI. It is unrelated to estrogen. And typically the pathology there is a serous histotype, and these have high-risk mutations like P53, and it is totally unrelated to the estrogen content, unlike the type 1, which are usually well differentiated and have a good prognosis. So among the type 2 cancers, we do have a small group of endometrioid cancers once again, but then they are very poorly differentiated, are high-grade tumors, grade 3 tumors, apart from the serous and clear cell types, whereas type 1 invariably are endometrioid grade 1 and 2. Luckily, vast majority of the endometrial cancers, once again, are just type 1, even when they occur in a postmenopausal setting. And it's only a small fraction of women, around 5 to 10%, will come under type 2. So now coming to today's topic, that is red flag signs. Any woman with an abnormal uterine bleeding, especially in a postmenopausal woman, and women who are aged 40 and over with high risk factors, and those with an abnormal discharge. This abnormal discharge we need to keep in mind, because they come with a little altered discharge. We think it could be a endometritis or atrophic vaginitis. They have a little purulent discharge, but what actually is happening is, because of the postmenopausal status, there can be a cervical stenosis, and any bleed or any lesion in the endometrial cavity can cause a pyometria and an associated abnormal purulent discharge. And in an asymptomatic woman who has a routine ultrasound, a thickened endometrium could be an indicator for an underlying disease. Similarly, once when we do a pap smear testing and we pick up an Agas lesion or adenocarcinoma in situ lesion, this could be an indicator of the underlying lesion in the endometrium rather than the cervix itself. And people who come with a little advanced stage can have other associated symptoms like a pelvic mass or lower abdominal pain, and more advanced disease have abdominal distension secondary to even ascites also. So when it comes to screening of endometrial cancer, the recommendation clearly states that even though these women who have a hyperestrogenic state like obesity, PCOS, and corpus cancer syndrome, the routine screening is not recommended. And this level of evidence is 3, and the level of recommendation is B. And many of the professional bodies, including our RCOG, ACOG, and the ESGO guidelines, clearly say there is no role for a routine surveillance on women with this kind of background risk. But however, there is definitely a place for screening for endometrial cancer in those women who are at increased risk. And who are these women? Those who have an granulosa cell tumor, any functional tumor of the ovary, those women with epithelial ovarian cancers in whom we are considering a fertility saving kind of a procedure, those women who are on tamoxifen, not necessarily because they are on tamoxifen, but because women with breast cancers are at a higher risk for endometrial cancer per se. And those women who are at high risk for endometrial cancers, like the hereditary Lynch syndrome, BRCA mutations, which I think further speakers are there down the line who will be elaborating on this. So these are the women in whom screening has a role, not otherwise. So once we think about a problem, then the next thing we need to do is a proper pelvic examination to see whether there is any lesion in the vagina, the cervix, and in the endometrium. Actually, recently we had a patient whom we operated for an endometrial CA, and for her, the lesion, she came to us with a vulval bulge, vulval lesion, and she had a suburethral nodule there, and that was what brought her to us. So a proper pelvic examination is a must, not only to rule out a lesion in the lower genital tract. Sometimes patients, they are not even aware through which orifice they are bleeding. They may have seen a little bleed or staining on their undergarments. They may not even be sure from which orifice it came, whether from the PR or from the urethra or the vagina. And for that reasons, a proper pelvic examination is a must, followed by an ultrasound scan. And in the ultrasound scan, we need to once measure the endometrial thickness, see the size of the lesion, if at all there is one, rule out ovarian disease, and assess whether there is any myometrial or cervical stromal extension. And nowadays we have very good ultrasound machines, and many centers which are doing an ultrasound do have a 3D ultrasound machine. They have Dopplers. All these things aid in picking up the lesions which are at a higher risk for being malignant. And we do have the sonohystogram, where in younger age group women, we have any suspicious polyp or something, then we can either put in a water or gel into the endometrial cavity and delineate the lesions for better evaluation later on. So when it comes to a woman with postmenopausal bleeding, the first thing we look for when you do an ultrasound is the endometrial thickness. And there is a clear-cut cutoff. When the endometrial thickness is more than 5 millimeters, then the chance of picking up a malignancy is as high as 15 to 20%. That is 1 in 5 women who have a thick endometrium more than 5 mm, then there is a chance that we pick up a malignancy, whereas the risk is less than 1% when the endometrial thickness is less than 5 mm. And but is it foolproof? No, not always. And endometrial thickness is not the only criteria we have to look at, because in nearly around, once again, 20% of the women, the endometrium itself is quite variegated in appearance and is very difficult to place our calipers. We are not even sure where the endometrial junction is, and the architecture itself is varied. So it is not measurable in nearly around 20% of the women, and in nearly 10%, it could be a thin endometrium, especially typically the type 2 ones. So for this, we have something called the IETA, that is the International Endometrial Tumor Analysis, which has come out with certain specific ultrasound characters in picking up endometrial cancer. So what we need to do here is, we have to closely look at the endomyometrial border, how it is. If it is irregular, associated with the thick endometrium, then there is a high probability. We have to look for the vascular pattern, whether there are any multiple focal vessels, whether there are any densely closely packed vessels. Then similarly, the surface of the lesion also is important. A large polyp kind of a lesion, which is very quite irregular in appearance, there's a higher chance it could be malignant. Similarly, any collection within the endometrial cavity also is a pointer towards an underlying endometrial cancer. But once we have a suspicion in our mind, then we need to, the gold standard of making a diagnosis is endometrial, is by a biopsy. And this biopsy can be done either through a PIPL or through a DNC. But there is a caveat here. Any blind approach to sample the endometrial cavity, studies have typically shown repeatedly that less than 50% of the cavity is sampled, and in 10% of the cases they are focal, and there is a high probability we could miss them. And so now the guidelines, international guidelines clearly say that blind biopsies like DNC and people are no longer offered to obtain an endometrial biopsy. But in a country resource setting like ours, if we are justified in doing a DNC or a people biopsy, and when there's a highly suspicious lesion and we are able to make a diagnosis based on these, then well and good, or otherwise we have to definitely go in for a hysteroscopy or a more guided biopsy. And many a times there is no correlation between the endometrial thickness and the focal lesion. Even when it looks like a thickened endometrium, when we put in a hysteroscope, it need not necessarily be a universal thickening. And many a times when we put in the hysteroscope, we see the lesion is quite focal and a proper biopsy needs to be taken. And this hysteroscopy nowadays, with the availability of thin scopes, especially Bitachi scopes, office hysteroscopy is being done in a large way in many centers. And without the patient needing an admission, she can just walk into the OP, have the procedure, and have a diagnosis made. These are some of the typical pictures of an endometrial hyperplasia, which is simple. See, there is a focal lesion. There could be a polypoid appearance, papillary appearance, or there can be a uniform thickening in a patient with endometrial hyperplasia. Whereas when the patient is having atypia, then there could be a more uniform thickening or a variegated appearance, like the color itself is different. At one place it's more yellowish, the other place could be a necrotic areas which are more white, which are more grayish. Or on the other hand, there could be a candy, sugar candy type of appearance, cotton wool type of appearance. Whereas a typical endometrial cancer could have any of these appearances, that is polypoid appearance, a papillary appearance, a nodular appearance, a cerebrated form of appearance, or even a glomerular type of appearance. And apart from the lesion, the other important thing is, like how we do in a colposcopy, we closely look for the vessels. When we do a hysteroscopy, a contact hysteroscopy, a very close or a magnified appearance will show us how the underlying vascular pattern is. When the vessels are thick and irregular, then there's a high probability of the lesion being malignant. And I just wanted to, those of you who are interested in having a good correlation between the patient's ultrasound picture and the hysteroscope and the pathology, I seek you to look out for the study by I think Amal Drishi, Drizi, from Italy. Recently, she gave a lecture in one of the webinars arranged by one of the gynec societies, and it was a very good lecture. And these pictures I picked up from her website, and it is a very nice paper, and she's doing a lot of good work correlating all the three factors. And the thing I need to insist here is the surgical plan for an endometrial cancer, which my subsequent speakers will be elaborating, is basically based on three factors. That is the histotype, the grade of the tumor, and the stage of the tumor. So whenever mean anything, we need to know whether it is an endometrioid or a non-endometrioid tumor. And even if it's an endometrioid tumor, we need to know the grade of the tumor, and of course definitely the stage. So these are the different physiological subtypes of endometrial cancer. The endometrial cancer grade 3, serous, clear cell, mixed, they all come under type 2 pathology, and they have to be treated like a patient with a ovarian tumor. There is a serous carcinoma, whereas endometrial cancer, endometrioid endometrial carcinoma grade 1 and 2, they are low risk cancers. And in this group, when we are sure that the tumor is limited to the endometrium or just only a superficial invasion, then even a simple hysterectomy without even a node dissection should be more than enough. And we don't need to have oncologists to do this kind of surgeries. Provided we are absolutely sure of the grade and the histotype and the stage of the tumor.
One more minute, madam.
Sure, ma'am. And just one few more slides. And the other important thing is once a diagnosis is made, then we go for further more extensive imaging like CT scan, MRI, and PET. And of the three, the important first stage advanced screening would be a MRI, because it gives a better tissue delineation and shows better whether there is any myometrial infiltration or not. Now, coming to the summary, the red flag signals for an endometrial cancer is any abnormal uterine bleeding in a postmenopausal woman, and irrespective of the age, women who are at increased risk for hyperestrogenic state, and who are at a high risk for endometrial cancer, as I said earlier, those with a high hereditary risk, and even in asymptomatic women when they are on HRT and tamoxifen, and when the endometrium shows a high thickness. See, when the women are on HRT and tamoxifen, the cutoff levels are a little different. When for a woman on these drugs, when endometrial thickness of more than 7 or 8 would warrant an investigation rather than the 5 in a postmenopausal woman. And in women with a high risk for endometrial cancer, that is a hyperestrogenic state, it depends on which stage or which day of the cycle we are doing it. If it is in the immediate post or in the proliferative phase, an endometrial thickness of more than 8 or 9 mm, or in a woman when we are doing it in the premenstrual phase, a thickness more than 15 to 16 has to be thought of as a hypoplasia and adequately monitored. And when those women who are at increased risk, that is the hereditary risk, and at once again a previous history of breast cancer, they are all a special group, and the care of management of these asymptomatic women group has to be on a case-to-case basis. And I come to the end of the presentation. Thank you once again for the patient hearing.
Thank you, Dr. Padma. That was very crisp and very clear on just knowing what are the things which you are supposed to know when you have a patient with endometrial cancer, because it is on the rise, and it was very crisp and clear. Very nice presentation, and I wish it was very useful for the subsequent speaker. It will be very useful how it is going to be handled off.
Thank you, ma'am.
Thank you, ma'am.
Next, let me introduce Dr. Shakti Usha, who is my student, who did her MD in Stanley Medical College, and she did her MCH Oncology in Kilpack Medical College, and she worked in government service for more than 23 years, and Arinjar Anna Memorial Cancer Hospital, and Karapete and Kanjipuram. And she's going to talk on surgical approach in endometrial cancer. Nowadays, because endometrial cancer becoming the commonest cancer in perimenopausal and postmenopausal women, definitely every gynecologist should know the importance of surgical approach in endometrial cancer, and when to deal with the patient and when to refer the patient to a surgical oncologist. And over to you, Dr. Shakti Usha. Dr. Shakti Usha, over to you.
Ma'am, please unmute, ma'am. Shakti, ma'am.
Sakiti, you have to share Sakti's PPT.
Okay, ma'am. Shakti, ma'am, please unmute. Yes, ma'am.
Okay, I have unmuted. This is today I am going to talk about the surgical management of endometrial cancer. As Madam has already pointed out, next slide. As Madam has already pointed out, this is it is not a single entity. It is a combination of so many types, histological subtypes. First, I would like to highlight about the disease burden in our institute. In our institute, the CA endometrium is accounting for only 2.73% of the newly diagnosed cases. but CA cervix is the main burden of us. CA endometrium accounts for 2.73% of the cases. Among them, it is early picked up. So usually 70 to 90% of the cases are picked up early. It accounts for 11% of the newly diagnosed cases, and averagely 158 cases in 2 to 3 years. You will get around 150 to 200 cases in 3 years. Then coming to the epidemiological pattern of the endometrial cancer, average age of occurrence is 63 years. Then it commonly presents as postmenopausal bleeding, as Madam has already pointed out. But it's only 10 to 15% of the patients with the postmenopausal bleeding will be diagnosed with endometrial cancer. Even though it is 90% of the cases are presenting with endometrial postmenopausal bleeding, but only 10 to 15% of the patients with the postmenopausal bleeding will be diagnosed with the CA endometrium. So as I have already told, that 70% of the cases it is early stage only. Then among stage 2 to 3, 10 to 20%, stage 4 metastatic disease, only 10% of the cases will be metastatic disease. Next slide, please. Then whenever there is surgery, surgery is mainly anatomy. When we need to do, it is dissection of the facial planes. So anatomy is very, very important. All of you are well versed with anatomy. Still, I would like to point out just what is endometrium, what is corpus uteri I want to highlight, because it is the part above the internal os. Everyone knows above the insertion of the tubes, there is fundus. Everyone knows that also. Remaining part is fundus, body of the uterus. Then the small part is isthmus. Then below, in between the internal os and external os, the part is the isthmus. Below that is the cervix. Every gynecologist is well versed with this thing. But coming to the regional nodes, we are this is part of the staging purpose, because this is part of staging. So parametrial nodes means there are very near the parametrium. Here they will be near the cervix. They will be obturator nodes will be in the obturator fossa below the external iliac vessels. Internal iliac nodes are along the internal iliac artery. External iliac artery along the external iliac nodes. Sacral and presacral nodes will be below the sacral promontory. Common iliac nodes, of course, they will be also over the common iliac vessels. Then parietic nodes. So these are the regional nodes. Parietic nodes extend from the crest of the diaphragm up to the bifurcation of the aorta. We need not bother about all the parietic nodes. Our regional node comes up to the inferior mesenteric artery. Below the inferior mesenteric artery, where are the parietic nodes for the uterine endometrium is from the renal hilum. Up to the renal hilum, the fundus vessels, fundus from the lymphatics. Uterus is highly enriched with the lymphatics. The fundus lymphatics will go through the ovarian pedicle. They will go up to the renal hilum. That is the point. So up to the renal hilum, the parietic nodes are regional nodes. Above the renal hilum, the parietic nodes are non-regional. This is the only thing I wanted to emphasize. Next slide. Before going to this thing, we need to do diagnosis by evaluation. As already pointed out by the previous speaker, this fractional curettage, Whipple's biopsy, and hysteroscopic biopsy. Hysteroscopic biopsies are important. This slide is speaking about MRI. MRI is the important imaging modality for the CA endometrium, because we should know the exact extent of the disease to assess our treatment planning. See, this is the normal endometrial lining. This is endometrial lining. This is the myometrium. If it is invading the myometrium means we need to do aggressive nodal staging. So if it is extending beyond the serosa, we need to do CA125 also. Again, nodal staging should be very aggressive. So this is the thing we need, because the MRI is the key sensitive part in assessing the myometrial invasion. We need to do MRI pelvis. Then CT abdominal pelvis to assess the nodes. PET CT also. If the distant metastatic spread is suspected, we need to do PET CT scan also. Next slide. So office endometrial biopsy is important. Even though this is simple procedure, no need for anesthesia. Accuracy is 90%, 99% sensitive, 98% specific. So it will do good. Unless if the clinching criteria, endometrial thickness, initially they were telling about 4 mm thickness itself, we need to do endometrial biopsy. Nowadays it is 5 mm. That is it's a recent criteria, 5 mm endometrial thickness in a postmenopausal woman warrant Whipple's curettage. Then fractional curettage if Whipple's is negative. Again, hysteroscopic directed biopsy. One is the opponents of what is the problem with hysteroscopic directed biopsy is when you insufflate water, there is insufflation of the spread of the tumors into the peritoneal fluid. When we are taking the peritoneal fluid for cytology, there is high chance of positive peritoneal cytology finding is there. If the patient has undergone histoscopic directed biopsy, there are chances of endometrial peritoneal wash coming up with the positive tumor cell is there. So it is not whether it is going to adversely affect the prognosis or not. Still, we need to see. Then, is there a role for CA125 in CA endometrium? Yes, there is a role. If we are suspecting extra uterine disease, we need to do CA125. Then it is an independent risk factor for nodal metastasis. So if we have the CA125 with us, it's okay. Then if we are planning for any neoadjuvant chemotherapy or neoadjuvant radiotherapy, it will predict the tumor response. So CA125 has 3 roles. It will predict the extrauterine disease. Extrauterine disease. It is an independent risk factor for the nodal metastasis. And also it will predict the response to your pre-treatment chemotherapy or radiotherapy. Next. Then this is the FIGO staging. They have just previous staging was small modifications only from the previous staging. FIGO is the standard everywhere followed. Stage 1, everyone knows it's confined to the uterus. 1A is less than 50% myometrial elevation. 1B more than myometrial elevation. Stage 2, it has gone beyond the uterus with the cervical stromal involvement. 3 is B and 3A, B, C. A is with the serous and adnexa involvement. B parametrium and vaginal involvement. C1 with when the pelvic nodes are positive. C2 parietic node. This is post-surgical staging only. We come to the staging workup. We will be knowing the exact stage of the patient. Then stage 4A is with rectum and bladder involvement. 4B is distal metastasis as well as non-regional metastasis. As I already told, parietic nodes, if it is extending beyond the renal hilum, means it is non-regional nodal involvement. Next slide. So what we are going to do? The early stages. What we are going to do for early stages? The early stage means stage 1. If it is uterine confined tumor. Deepa, next slide.
Next slide, Pa.
Before that, prognostic factors. Prognostic factors are important. As I have as already pointed out by the previous speaker, prognostic factors are important to assess the prognosis as well as to design the surgery. What surgery we will do, then to plan for the adjuvant and adjuvant treatment. So for prognostication as well as planning adjuvant treatment, TNM staging is important. Higher the TNM staging versus the prognosis. Stage 1 good prognosis. Everyone knows. Then FIGO staging also. Higher the staging, stage 4 is worst prognosis. Stage 1, 70 to 90% survival rate. Stage 2, 50% 5-year survival rate. Everything like that. Grade is also very important prognostic factor. Grade 1 means here grading is by molar pattern and grade 1 less than 5% non-squamous non-molar growth pattern means grade 1 that is 5%. 50%, more than 50% non-squamous non-molar growth pattern means grade 3. Grade 3 is associated with worst prognosis. And depth of myometrial invasion. This depth of myometrial invasion is also important prognostic factor. Lower the depth, no myometrial invasion means good prognosis. Lymphovascular space invasion is again, it will predict the nodal metastasis. It will predict the nodal metastasis as well as myometrial invasion also somehow correlate with the depth of invasion. So histology is very, very important. This is as this endometrial CA is not a single entity. This endometrial high risk histologies, that is clear cell, serous, the other high risk histologies are associated with a very worst prognosis. Then age is very, very important bad prognostic factor because more than 60 years age group means that's worst prognosis. Lesser the age group, best prognosis. More higher the age group, worst prognosis. Because older patients will be having aggressive histological subtype. They will be having advanced endometrial cancer. That's why they are having worst prognosis. Next, coming to the surgical per se, how will you treat the early stage? So surgical treatment, when the disease is limited to the uterus, when it is early stage, we have multiple options. We can do surgical staging either by robotically or laparoscopically or open technique. All the 3 methods can be used when the disease is limited to the uterus only. Then nodal staging also we can do sentinel node. We need not do entire pelvic lymphadenectomy. We can avoid nodal staging. We can do sentinel lymphadenectomy. We can do systematic pelvic lymphadenectomy. What are the scenarios I will tell. So actual surgical staging, what we should do after opening the abdomen. This is a phalangeal incision we can do in early stages if we are very sure. So there is fluid, ascitic fluid means we have to take the fluid. If there is no fluid, means we need to put 100 ml of saline. Saline wash we will give. We need to take. Then we need to take the peritoneal wash cytology. Then we need to systematically explore the abdomen, whether there is diseases limited to the uterus, whether it is extending beyond the serosa, or it is involving the adnexa or tubes, whether it has involved the tubes or ovaries, we need to see. If there is any peritoneal deposits, any liver deposits, mesenteries are normal, everything we need to explore the abdomen. Then we need to proceed with the total hysterectomy and bilateral salpingo-oophorectomy. Total hysterectomy is extrafacial hysterectomy, extrafacial type 1 hysterectomy. It's a type A. Nowadays, ABCD classification of radical hysterectomy is there. So we need to do type A extrafacial hysterectomy with bilateral salpingo-oophorectomy. There is a question now is whether we need to remove ovaries for all the patients. The question is, we don't know. There is a risk of involvement of the ovaries in 8% of the cases in early stages, 8% involvement of the adnexa. So better if we remove the ovaries. Another thing is, we have the symptomatic patients. The beauty of CA endometrium is it will be symptomatic, but CA in the early stages. But CA ovary won't be symptomatic in early stages. So it will be when patient is coming with the CA ovary means it will be already the stage 3C or mostly stage 3C. So it is better if we remove the ovaries unless the patient is desirous of fertility, organ preservation. There is a role for organ preservation here. If the patient wants, if there is pure endometrial histology, the patient is pure endometrial histology, confined to the endometrium, no myometrial invasion, no LBSA means there is a role for preservation of the ovaries. Then evaluation of the lymph node, complete pelvic and parietic lymph nodes. Parietic lymph nodes we can omit for early stages. Then omental biopsy also we can omit. Omental biopsy only for high-risk histologies. Omental biopsy, because serous clear cell and carcinosarcoma histologies will behave like an ovarian malignancy. So we need to take the ovarian, that omental biopsy also. For stage 2 disease means disease with the cervix involved. Cervix involved, previously guidelines were saying we need to do Verdim cystectomy. Stage 2 disease, we need to do Verdim cystectomy was previously the standard of care. Now, what guidelines are telling means if you are getting away, if you are able to get away with negative margins, if your parametric cut margins are free, you can still do a total hysterectomy with bilateral salpingo-oophorectomy alone with pelvic lymph routine staging procedure. So radical hysterectomy only to get negative margins. If you are not sure about negative margins, then you need to do de-roof the ureter, take the parametrium as lateral as possible, then do Verdim cystectomy. So Verdim cystectomy is not mandatory for stage 2 if you can get negative margins with your hysterectomy. But it's important to get negative margins. That is the point I want to emphasize here. Then how will you address the nodes for early stages? So this can be done with the robotic. Next slide. So surgical approach, early stages only. I am emphasizing repeatedly early stage endometrioid histology, grade 1 histology, laparoscopic stages acceptable. Laparoscopic staging can be done. It is introduced in 90s. So there are supports. It is safe and oncological outcome also good. There are multiple supports. To highlight one, there's a lab 2 trial which is Gynec Oncology Committee conducted. It is associated with open surgery in 25% of the cases. Operating time was quite a little bit longer because of lab exposure is needed. So as everybody knows, lab approach will be always associated with a shorter hospital stay, but it is laparoscopic approaches associated with some more intraoperative complications. Perioperative mortality equal group. Only the importance is no difference in oncological outcome. So it is similar results also obtained with robotic approaches also. So there is no difference in oncological outcome. We can early stages, endometrioid histology, low risk group, we can that is without myometrial invasion, we can do laparoscopic approach as well as robotic approach also can be done safely. What decides which approach is best is next slide. So minimally invasive surgery, when you will choose depending upon the patient characteristic, disease characteristics, uterine factor and surgeon's experience, of course. Patients who are very obese with so many comorbidities, with diabetes mellitus, they are not suitable for minimally invasive procedure. Slightly overweight, broad pelvis, few comorbidities, no previous surgeries are ideal candidates for lab procedure. Why is because for parietic lymphadenectomy and all, we need to mobilize entire intestine into the upper abdomen. So if it is small, if short mesentery is there or the abdomen is small, it is very difficult to pack. In obese people, there is also the vessels will be covered with fat. The uterine artery, vein, and the ureter and all, they will be covered with the fat. So there is very difficult to do the very difficult. So it is associated with a little bit extra morbidity. So ideal candidates will be patients with slightly overweight, few comorbidities, little or no previous surgery. Next. So that is I told that is robotic surgery is also preferable. So BMI should be less than 35, not more than 35. If more than 35, better go for robotic surgery. So short mesenteric length severely limit the ability to stage because we need to pack the entire intestine into the upper abdomen to assess the parietic nodes. So there will be difficulty in packing the bowel. So it is better to open surgery. So central obesity, fat will be impeding the exposure of the lymphatic beds, making a cumbersome process. So surgeon's expertise is also important and patience. That is also successful minimally invasive procedure. These are the factors associated with successful outcome without conversion into open for early stage endometrial cancer. Then pelvic lymphadenectomies. Pelvic lymphadenectomy, how will you do? Where will you avoid? Next slide. So before going to the lymphadenectomy, I would like to point out this grade 1 tumors, endometrial involvement is 0.8. Grade 1 with endometrial involvement only means there is pelvic and parietic node positivity is 0.8. The same tumor with the serosa involved means, uterine serosa involved means, pelvic and parietic node positivity goes up to 28% even in the grade 1. So abnormal histology also, serous and clear cell histology also, even the tumor is confined to the endometrium, still there is risk of pelvic and parietic nodal metastasis. Serosa, in the serous histology, 66% positive rate you can get with the pelvic and parietic nodal metastasis. So with this scenario, with this picture in mind, we need to do which patient requires systematic pelvic lymphadenectomy, which patient requires sentinel node biopsy, which patient requires systematic parietic node sampling versus parietic nodal dissection. Next slide. So again the same thing. The incidence of clinical stage 1 patients only 7.4 to 13.3 only. There is the risk of metastasis, nodal metastasis. So 2 large randomized controlled trials showed that lymphadenectomy did not change the survival, and it is not a staging procedure only. It is not a therapeutic procedure. You can stage the disease. You can upstage. If a node becomes positive, it will be upstaging, but it is not a therapeutic procedure. This is a trial based on Aztec trial, and there is a Italian-based trial. This is the early stage endometrial cancers only. Early stage endometrial cancer, lymphadenectomy didn't have survival advantage. It is not a therapeutic procedure. But these things are very controversial. These findings. Next slide. So when will you omitting lymphadenectomy? When will you omit lymphadenectomy? You can omit lymphadenectomy in grade 1 to 2 tumors with less than 50% myometrial invasion, no LVSI. This is endometrioid histology only. Endometrioid histology, grade 1 and 2 tumors, less than 50% invasion. Uterine confined tumors, no LVSI. Tumor diameter is 2 centimeter or less. So final pathology is not going to give nodal disease. So this is controversial, but this is the only scenario you can avoid lymphadenectomy. You need not do lymphadenectomy. There should not be any myometrial invasion. The tumor size should be less than 2 centimeters. Grade 1 and grade 2 tumors only with no lymphomuscular space invasion. But if we are omitting lymphadenectomy by going by this criteria means our final histopathology, our pathologist will ditch us by giving final histopathology as grade 3 tumors. They will give, even though MRI says less than 5%, 50% myometrial invasion, your final HV will show more than 50% myometrial invasion. So these are the things only for theory. We need to do pelvic lymphadenectomy for all cases for surgical staging. Next slide.
Madam, 2 more minutes, madam.
So since it's a controversy whether to do or not, then comes the sentinel node mapping for CA endometrium. So again, this is for only uterine confined malignancy. A cervical injection. This is nothing but you are going to inject the cervix with the isosulfan blue, mercury blue, or pattern blue. Or if you have infrared camera, you can do this iodocyanine green also. The 4 sites or 2 sites will be chosen in the cervix. You will be infiltrating the cervix with the dye or radioactive colloid. We will be inspecting by open approach. Open the pelvic nodal basin whether it has any lymph nodes has taken up the dye. So we need to take up the dye alone. We need to take up the lymph node alone, send it for ultra staging, ultra microscopic examination, whether they are involved with the disease or not. That is the thing we need to do with the sentinel node mapping. This is coming up for early endometrial cancers. We have done with the iodocene green camera. We have positive nodes. So if the node is positive, one side only, we need to address that side only. We can avoid the opposite side, pelvic lymphadenectomy. If nothing is picked up, we need to do systematic pelvic lymphadenectomy. And we need to remove the vastly enlarged node also. We need to do pelvic lymphadenectomy. This is the role for this is the sentinel node mapping stage. This is middle road traveling. You are not going just sampling. You are not doing systematic sampling. Also, you are not doing. We are doing sentinel node mapping. Next slide. So this is the dye injection sites. Where will you inject dyes for cervical this thing? This is the most common area we will pick up sentinel nodes, pre-sacral region, and external iliac node. This is the umbilical artery area. This is the area where we will pick up endometrial commonly picked up. These are least common areas. These are the least common areas. Green ones are most common areas. Blue ones are least common areas. These are the most common areas of the sentinel node areas. Next slide. So after serious evaluation, you are injecting. So systematic pelvic lymphadenectomy, site-specific lymphadenectomy alone performed. Parasitic lymph node, if a high risk histology is there, we need to do parasitic lymphadenectomy. This is the algorithm for sentinel lymph node biopsy. The next slide. Then parasitic lymph node. Parasitic lymphadenectomy, when will you do? Only for advanced stages. Advanced stages, high risk histology. High risk histology, we need to do serous histology and all. We need to do parasitic lymphadenectomy. Parasitic lymphadenectomy is has prognostic value. It is unlike unless pelvic lymphadenectomy, which has no prognostic value. This has therapeutic value also. In recent GOG protocols, the inferior mesenteric artery is the upper border of lymphadenectomy for endometrial cancer. But the tumor is located in the fundus, means fundus located tumors, we need to do beyond the up to renal hilum, we need to do. Up to renal hilum, we need to do parasitic lymphadenectomy. So 2.6% of the patient with type 2 disease, type 1 and 4.1 with will be having parasitic nodes. So they are most likely, we need to parasitic lymph node positive means we need to give systemic therapy, chemotherapy for the patient. That's why it is dictating the prognosis and it will direct the treatment for high risk cases also. So parasitic lymphadenectomy is important for advanced cases, not early cases. Early case, you can omit pelvic lymphadenectomy also as well as parasitic lymph node. Next slide. Coming to this, what will you do for local advanced cases? Local advanced cases, you have to see whether after imaging, you need to see whether the patient is suitable for primary surgery, whether it will debulk, whether there is any deposits. We can remove the rectal tumor, rectal deposits or ovary deposits. Whether you can adequately remove, you need to assess with imaging. If you are very confident, you can give arterial resection. You will completely remove the tumor means we can straight away proceed with the surgery that is called debulking surgery for local advanced cases. It's only for endometrial histology. When you feel the patient is not suitable for primary surgery, we need to give external beam radiotherapy with or without brachytherapy. Then re-evaluate the patient with the clinical examination as well as imaging. Then proceed for surgery. So still there is a role for preoperative systemic therapy also. If the patient is not filling for radiotherapy or brachytherapy, we can give preoperative systemic therapy, then reassess the patient for response. So locally advanced means they have gone beyond the cervix. Beyond the cervix, they have gone to nodes or they have gone to ovary and all. Not metastatic, non-metastatic diseases. Non-metastatic diseases, we can give neoadjuvant treatment, neoadjuvant radiotherapy. There is a role for neoadjuvant radiotherapy as well as neoadjuvant chemotherapy. Next slide. So when will you do when there is recurrence? You have completely treated the patient, you have surgically staged, given brachytherapy or radiotherapy, actual treatment also. Patient is coming with the recurrence means you will image, you will see the patient, clinical examine the patient. There is no distant metastasis there. It's a pelvic confined disease. It is operable means you can surgically explore and you do resection. Or if there is no priority is given, you can do straight away give the patient external beam radiotherapy with brachytherapy also. Next slide. So this is the commonest scenario and gynecologists will be encountering. It is the incidentally detected endometrioid histology after hysterectomy. You have done hysterectomy. The final, even though if you have done pap smear, everything, DNC, everything has come out endometrial hyperplasia only, moderately severe endometrial hyperplasia, but final HPE has come as endometrioid histology, PCA endometrium. What will you do? So whether to do lymphadenectomy or not. This is the scenario, whether we need to do restaging and all. So what are the parameters you will be looking into? You will be looking into whether the patient is stage 1A. Stage 1A means 50% myometrial, less than 50% myometrial invasion. So age is less than 60. No lymphovascular space invasion. So grade of the tumor is 1 and 2. This all criteria should be met. So you can avoid restaging. You need not do restaging for the patient. So you can avoid restaging. The all criteria are met. You can put the patient on observation. Then in grade 3 tumors also, uterine endometrium confined disease. It has no myometrial invasion. It is not stage 1A, even before A1A. No, it is not 50% myometrial invasion. It is no myometrial invasion. No myometrial invasion, which is a little bit higher grading also, with other criteria met, like age less than 60, no LVSA, we can put the patient under observation. These are the only two scenarios. You can avoid restaging. You need not do pelvic lymphadenectomy, you need not do anything. So you can straight away observe the patient with no redoing of surgery, no restaging is needed. So these are the only scenario we are choosing for observation. What are the other scenarios? Next slide. Other cases, you need to do, if it is advanced stage, if it is more than beyond stage 1A grade 3 means, imaging with the CEC abdomen and pelvis you need to do. If the stage is stage 2, you can do surgery means you need to do surgical restaging of the patient. If the patient is more than stage 2, stage 3A, straight away the patient is candidate for adjuvant treatment. So you can straight away send the patient for adjuvant RT. These are based on NCCN guidelines. Then next slide. So our next speaker, I don't know, next is going to talk on fertility sparing options. Anyway, I put this right. So when will you do fertility sparing or organ preservation approach? Organ preservation approach, when the patient is with the reproductive age, wants childbearing means all the criteria should be met with before proceeding for fertility preservation. So it should be well differentiated, endometrioid, double pathologist confirmation, confirmed by pathologist. Two pathologists should confirm. One pathologist is certifying, another pathologist should review. It is only G1 because when we have, there is so much asynchrony. Initially, we will be having no myometrial invasion, then the final pathology will come as myometrial invasion. Initially, the grade will be grade 1, final pathology will say grade 3. Likewise, there should be no discordancy. So it should be confirmed by pathological review. Then the disease is limited by endometrium, limited to the endometrium by MRI and TVS. No metastasis, no contraindications on medical therapy. Patient should be counseled. Patient should be repeatedly told this is not standard of care. Patient should be repeatedly told, informed that.
Madam.
Okay. See, next. So progesterone therapy. These are the therapy. So take home messages. Early stage C endometrium, TH with BSO with pelvic lymphadenectomy, without paratic nodes. Late stages, there is a role for cytoreductive surgery. Incompletely staged option, completion staging depending upon the high risk features. Paratic nodal dissection for high risk cases only. Sentinel node mapping for high risk endometrial CA. Minimally invasive surgery has equal oncological outcome in early stages. Thank you for the opportunity. Thank you. Thank you, ma'am.
Oh, yeah. Thank you, Satyusha, for your detailed, elaborate note about surgical approaches in various stages and how to do the procedure according to the staging, grade, and histological type, when to do the lymphadenectomy, when to omit lymphadenectomy, and post-surgically, if you find an endometrioid carcinoma, how to manage these cases, when to do restaging or when to do the adjuvant therapy. Thank you, Satyusha, for your detailed note. Thank you very much.
Pragati, next presenter, Dr. Sheba.
Okay, ma'am.
Dr. Sheba is there, na?
Yeah, I'm here, Dr. Deepa.
Yeah, let me introduce next speaker, Dr. Shiva S.K. Jacob. who has the DNP, and she's a senior consultant and pathologist in Apollo Main Hospital. Over to you, ma'am.
Good afternoon, everyone. Thank you for the wonderful introduction. I have given a presentation to Dr. Deepa.
Yeah. Wait, Dr. Sakit from Dr. Sakit.
Okay, sure.
Shall I,
Yeah.
shall I
Her
share the
PPT
screen,
Sakit.
ma'am?
Yeah.
Okay, ma'am. Just a second, ma'am.
Everyone. Today's histopathology topic is staging and grading of endometrial carcinomas. I thank the organizers for giving me this opportunity. The most dreaded biopsy diagnosis around the perimenopausal or menopausal period is endometrial carcinoma. The incidence of endometrial carcinoma in India is 4.3 per 100,000 women, and it is increasing due to lifestyle changes. The median age of diagnosis is 63 years. Women in the US, the incidence is around 27.7 per 100,000, and it's the fourth most prevalent cancer in women. Historically, the endometrial carcinomas were classified as estrogen dependent or non-dependent. Endometrial carcinomas were estrogen dependent, and serous and clear cell were non-dependent on the estrogen status. The latest WHO classification incorporates pole mutations, microsatellite instability, and p53 mutations into the classification. So we need the help of immunohistochemistry and next-gen sequencing for classifying appropriately. Cancer stage is the strongest predictor of outcome. Two main staging systems are used, that is FIGO staging and TNM staging. At present, both are currently harmonized. Coming to TNM staging, T1 meaning the tumor is confined to the uterus, body of the uterus, including endocervical glandular involvement. T1A meaning it is limited to the endometrium or invades less than 50% of the endometrium. T1B meaning more than one half of the myometrium is involved by the tumor. T2 means the tumor invades the cervical stromal connective tissue. T3A means the tumor involves the serosa and adnexal structures. T3B meaning the tumor involves the vagina. Or parametrial involvement is also included in T3. Tumor involves the bladder mucosa or the bowel mucosa in T4. Coming to the lymph nodes, the most common drainage area for endometrial carcinoma is the pelvic lymph nodes and the para-aortic lymph nodes. So coming to pelvic lymph nodes, we see whether there is only isolated tumor cells. That is, you can see in the diagram, there are in the photograph that is projected above, there are single brown cells. Those are all isolated cells. If they are present, it is classified as TN0I+. If in the pelvic lymph node the metastasis size is between 0.2 and 2 millimeters, it is N1MI. and it is N1A if the size is more than 2 millimeters. Similarly, in para-aortic lymph nodes, if the size is less than 2 millimeters, it is N2MI, and more than 2 millimeters is N2A. Para-aortic lymph node involvement can be noted with or without involvement of the pelvic lymph nodes. Coming to M1 category, that is the M category, that is the distant metastasis. So you can see 3 dotted lines. If the metastasis is above that para-aortic lymph node level, then it is M1 category. It can be below the dotted lines drawn below that third line. If it occurs, that is also M1 category. So inguinal lymph node metastasis or intraperitoneal disease and metastasis to the lung, liver and bone comes under the M1 category. FIGO stage, as I said, it is similar to TNM staging nowadays. So cancer stage is the strongest predictor of outcome. Staging requires evaluation of the resection specimen. So first what we do is we examine the outer surface, and then we cut the specimen appropriately and find the extent of the tumor grossly. Then we take appropriate samples and examine microscopically. Cancer stage is the strongest predictor of outcome. More than 90% of stage 1 carcinomas have a good outcome, and only 15% of the stage 4 carcinomas have a disease-free 5-year survival rate. The other prognostic histological variables are myometrial invasion, cervical stromal involvement, serosal involvement, adnexal involvement, lymph node involvement, histologic type, tumor grade, vascular space invasion, and the molecular group. Coming to myometrial invasion, as you can see the gross picture over there, the cut surface of the uterus, there is a blue arrow marking the depth of invasion. So we sample from that area where the depth of invasion is maximum grossly, and then we examine under the microscope. So below A, B, C, D, E are the images, different types of invasion. And if there is adenomyosis, we measure the invasion from that level. So these are some of the microscopic images showing the invasion. So here you can see glands invading the myometrium surrounded by this desmoplastic reaction, and also there is some inflammation. This is another picture showing endometrial carcinoma involving the adenomyosis, and the arrow marks the invasive area adjacent to it. This is another picture, high power view, showing the desmoplastic reaction around the invasive focus. The next thing is cervical stromal involvement. Upstage is the tumor. So if the tumor involves epithelial like lining epithelium, it doesn't upstage the tumor. But if there is stromal involvement, as you see in this microscopic photo, it upstages. Next is we look for any serosal and adnexal involvement. Then coming to microscopy, we type the tumor. So different types of tumor have prognosis is different, and the treatment is also different. Then we grade the tumor, we look for any lymphovascular space involvement, and then we classify them according to the molecular category. So this is the latest WHO classification, that is endometrioid carcinoma. That depending on the mutation, it's classified into pole ultra mutated endometrioid carcinoma, mismatch repair deficient endometrioid carcinoma, P53 mutant endometrioid carcinoma. And if no specific molecular profile is present, if the above three is not present, it is classified as NSMP. Then comes mucinous carcinoma. Then the high grade carcinoma, serous clear cell carcinosarcomas, neuroendocrine carcinoma variants, mesonephric carcinoma, squamous cell carcinoma, and finally dedifferentiated or undifferentiated carcinomas. Coming to the grading, serous and clear cell, directly they become high grade. Endometrioid and mucinous carcinomas are graded accordingly, figure 1, 2, and 3, depending on the percentage of the non-squamous solid component. And they are upgraded by 1 if severe nuclear atypia is present. We also look for lymphovascular space invasion. It's not only we have to identify that, we also have to mention the extent of lymphovascular invasion, because it is a predictor of local recurrence and nodal metastasis. Coming to the molecular subtypes of endometrial carcinoma, we look for pole mutation using next-gen sequencer. And we do immunohistochemistry to look for P53 mutation or mismatch repair protein status. So if all of them are intact, it comes under the no specific molecular group. So this is a pie diagram showing the percentage of the mutations present in endometrial carcinomas. So as you can see in the diagram, pole mutation has the good prognosis and P53 mutation has a bad prognosis. This is another diagram showing the list of tumors and the mutations involved in it. As you can see, endometrioid low-grade carcinomas, most of them don't have any specific mutation. At the same time, higher number of P53 mutations is noted in serous and carcinosarcomas. Little bit about other markers. We also, like in breast carcinomas, we also do estrogen and progesterone receptor status for endocrine therapy. This is estrogen receptor positive tumor. You can see the brown staining of the nucleus, that is positivity. This is progesterone receptor. This is P53 mutation status. You can see the P53 has brightly stained almost all the nuclei of the tumor cells. We also look for HER2 status as in breast carcinomas nowadays. This is also useful in treatment of high-grade tumors. In recurrent MMR deficient or MSI high tumors, it might be useful to use an anti-PD-1 drug. So that status is also important, not only for prognosis and for treatment. This is an endometrial carcinoma. So these are the markers we use to study the mismatch repair protein status. This is MLH1. This is negative. This is MSH2. This is positive, or what we say is intact nuclear expression. This is positive MSH6. This is negative PMS2. So if these markers are negative, then we suspect microsatellite instability. And also Lynch syndrome, if the patient has Lynch syndrome, they present at a younger age group and they have low BMI and the risk of developing endometrial and ovarian cancer exceeds that of colorectal cancer. So surveillance is very essential. These are the other mutations that can occur in endometrial carcinomas. Coming to the lymph node status, as I said, pelvic and para-aortic lymph nodes are involved commonly. So we might take the help of frozen sections sometimes to decide whether we need to do lymph node sampling or not. So if the tumor is more than 2 centimeter or high grade, directly you go on to sample the lymph nodes. But if it is low grade and the size is less than 2 centimeter, take the help of frozen section. And still, if the myometal invasion is more than 50% and it is high grade, you can go for lymph node sampling. Coming to sentinel lymph node sampling, sentinel lymph node is nothing but the first lymph node to drain the tumor region. So either technetium or methylene blue or indocyanin green dye is injected around peritumoral or around the cervix area, and the first group of lymph nodes to be drained are examined in frozen sections. So that way we can decide whether we can do lymph node sampling or not. Metastasis can also occur to the bone, brain, liver, lung, and skin, and local recurrences are common in the vaginal vault and the pelvis. These are my references. Little bit take-home message. Better to send an intact specimen to the pathology department. Cold ischemia time should be minimum, that is the time elapsed between after the removal of the specimen into the formalin should be minimum in order for the immunohistochemistry or the molecular testing to be done adequately. Frozen section, if needed, can be utilized. And nowadays we use molecular or immunohistochemistry techniques for categorization. Thank you for your time.
Thank you, Dr. Shiva.
Thank you, Dr. Thank you, Dr. Shiva, for the nice presentation on pathologists, because the final diagnosis and the management depends on the pathologist. Ultimately, we depend on the pathologist for the staging and also for the prognosis. So it was excellent about giving us the tips like the cold ischemia time, which has to be stressed on to all the postgraduates, like when it has to be put into the formalin, that is playing a very important role. Now with the immunohistochemistry coming in, we have to be very careful in managing such cases. Thank you, Dr. Shiva, for your elaborate note on the pathologist role in management of endometrial cancer.
Thank you for the opportunity. Thank you.
Thank you, Sumati ma'am, and thank you, Vasantamani madam.
Okay, ma'am. Thank you. Thank you, Deepa ma'am, and thank you, Jairani comrades and Kundami ma'am, for giving an opportunity to share this session. Thank you.
Yeah. Dr. Shri, the previous speakers can stay online. If there is any question on question answer sessions, please reply for the session, reply for on QA itself. If there is any interactions, join us with around 4:45 to 5 o'clock. We'll move on to the next sessions. For the next section, may I invite Epsiba Kribamani madam and Dr. Mangala Geeta for chairing the session. Epsiba madam is none other than, everyone knows her. She's a president, Chennai Menopausal Society. She is a former superintendent of Stanley Medical College and currently a professor in Savita University. She is a past president of Society of Obstetric Gynecology Society of Southern India. And she had many awards to her. And over to you, madam. And second, may I invite Dr. Mangala Geeta. She is a professor HOD, Department of OBG, Government Medical College, Omundurar Government Estate. She is a postgraduate from Madras Medical College and MBA in Health Service Management from Anna University, Guindy. She has a teaching experience for more than 20 years. She's all very much interested in microsurgery and laparoscopy and high-risk obstetrics. Over to you, chairpersons. FC, madam?
Yes, yeah. At the outset, I thank the OXI, Dr. President Jairani, Secretary Kundavi, and the Cancer Cervix Committee, Dr. Dana, and the co-chair, Dr. Deepa, for giving me an opportunity. It's my privilege to introduce my friend, Dr. Gopinath. He does not require any introduction to this audience. He is currently the Director and Senior Consultant, Institute of OBG and IVF, SRM Institute, and he is the right person to talk about the fertility preservation with endometrial carcinoma. He has been trained in fertility preservation from Israel, and he is the President of Fertility Preservation Society of India, member of International Fertility Preservation Society, and he is the past president of OXI, founder president of SAFASI, founder secretary of FSI Tamil Nadu branch, and member of ESHRE, ASRM, IAG, ISR, and ASRM board certified andrologist also. And he has received a lot of awards. To name them few, Lifetime Achievement Award, he has received it, and Leading Light in ART from IFS Cochin, and Icon of the Year in South India 2019, and he has been recently awarded Lifetime Achievement Award from IMA also. So over to Dr. P.M. Gopinath.
Thank you, Ipsi. Thank you for your kind words. And I thank OXI for the opportunity given. Previous speakers have made my job a bit easier, and fertility preservation in endometrial cancer. So we are planning to cover the preamble, candidate for fertility preservation, evaluation, fertility sparing options, medical and surgical, ART, and then we are going to conclude. We thought it is a disease of older, say about more than 60 years. But today, because of various reasons, we are seeing cases even at the reproductive age group, younger age group, probably because of the excessive use of the estrogens, or probably we are picking it out a little earlier. So there is a lot of increased awareness about this endometrial carcinoma. Just to highlight it, what we are confining it to you, it is where exactly it should be there. So we have distinctly seen the different types, type 1 and type 2. So the proportion you will see there in type 1, it's about 85% are unopposed to estrogen. They are endometrioid and they are low-grade tumors. And then they are presenting at 1 or 2, and 5-year survival is more than 80. This is the place where you have to hitch for fertility preservation. There are various classifications given for different kinds of a thing. What we are seeing is only the first line, the low, where stage 1A, EEC grade 1, and 2 without substantial lymphovascular invasion. Only this is confined to your fertility preservation. What are the candidates for conservative management? The National Comprehensive Cancer Network's selection criteria has been taken. European Society for Gynecological Oncology Task Force recommendation for fertility preservation were taken. British Gynecological Cancer Society and Royal College of Obstetricians and Gynecologists criteria is taken. All put together, what they just say, it is grade 1 endometrial adenocarcinoma with histology and grade confirmed on DNC. Tumor confined to endometrium by imaging studies, preferably an MRI, and they should not have any contraindication to hormonal therapies. And then the patient should undergo counseling, and this is not a standard care, and the risk involved with pursuing these courses of treatment should be explained. This is the 4 distinct criteria we look for in continuing. Over and again, the diagnostic evaluation is very vital because the standard care is something like a bilateral oophorectomy, which we want to use it for fertility preservation. If we are leaving behind, we have to be very, very careful about the evaluation. So initially we mentioned it about endometrial biopsy, and even one of my previous speakers was mentioning about the PIPL. But if you look at the accuracy of PIPL and DNC, so it is about 17.4% of the patient has been sampled with PIPL, and 8.7% of the patient has been on the upgraded case. So that means the DNC, the conventional dilatation and curettage, is very high accuracy and is related to the larger sample provided for this method. So if at all, if you want to preserve, please go for a DNC rather than PIPL endometrial biopsy, where if facilities are available, you can go in for hysteroscopic tumor resection, and then DNC should be suggested by several authors for this. Now, about the myometrial invasion, if there is an invasion, it is a poor prognostic factor. So if there is a deeper invasion, risk of nodal and parametrial involvement is there. So we have to very clearly look at this invasion by an MRI. So these are all different types of imaging where you will see that the vasculature shows only up to the level. It does not go beyond that. Here you will see from stage 1, 1, 2, 3, 4, and then how it is just going beyond the vasculature. Ideally, we get an image of only an endometrial cavity like this. So if you carefully look here, you see the growth is coming from the body, but it is being extruded into the cervix. It does not extend from cervix. So if you see a growth like this, then it is only a type FIGO 1A. So that is more important there. In MRI is, as I have just mentioned it, when the facility is available, has to be utilized it. Here, you look at the plane. This is the cavity where you will be very clearly able to see that. These are all the criteria staging MRI for endometrial cancer. You look at the uterine size, myometrial depth of invasion, cervical stromal involvement, extrauterine extension, and if there is a suspicious nodes, look at the pelvic side walls and parametrium, and then this is the staging done only by an MRI. And it has got a very small role. If you have a borderline patient where you want to preserve, still you can just go in for a PET scan and rule out it is only not beyond 1, and then you can just plan for that. What are all the fertility sparing options for management of endometrial cancer? One is hormonal treatment modalities. It is most suited, and then either we can use a medroxyprogesterone acetate or progesterone releasing intrauterine device. Progesterones have always got an anti-proliferative and stabilizing effect of the endometrium. So the use of hormonal therapy until the completion of the childbearing does not appear to be worsen the oncological outcomes in stage endometrioid cancers there. So the treatment, the dose varies from about 100 to 400 milligram of medroxyprogesterone acetate, or about medroxyprogesterone acetate, they have been selling it somewhere around between 20 and 1,500. So here you have to be very, very careful, and this is the image of the pre and post therapy where you see sleep with it. The second alternative is to go in for levonorgestrel IUD. It has been increasingly utilized for fertility sparing treatment of endometrial cancers. There is a study with about 46%. The response rates was about 80%, and then 67% with grade 1 adenocarcinomas has been utilized there. So the Cochrane review comparing the LNG IUCD with 20 micrograms daily to 10 milligrams of medroxyprogesterone found insufficient evidence to support the superiority of either one. So that means we can still look for LNG IUCDs there. There is a role of metformin. It is usually given for insulin resistance and hyperinsulinemia in endometrial carcinomas. So it has been shown to decrease gluconeogenesis, improve insulin sensitization, decrease the circulating insulin levels, and exert an inhibitory effect of the proliferation and invasiveness of the endometrial cells on the preclinical studies. So with that, it has got a definite positive role. What about the surgical treatment modalities? The hysteroscopic resection followed by an oral or intrauterine device progesterone is a standard care to preserve fertility in patients with early stages there. The women who receive this treatment modalities achieve the highest the complete remission rate compared to the other existing fertility options. So resection with oral or intrauterine device is probably the best here. The eligible patients wishing to preserve the future childbearing should be aware that this is a conservative treatment, may be followed by hysterectomy with salpingo-oophorectomy to prevent the disease relapse later after the childbearing is completed there, which we have to highlight to them there. The earliest reports on the Lynch syndrome, who has underwent hysteroscopic polypectomy, displaying endometrial cancer after pathology analysis there. So here again, the management is medroxyprogesterone acetate for 3 months, and patient achieving pregnancy 3 months after concluding the treatment should be planned accordingly. Hysteroscopic surgery, then you very well know, then it is very easier and to see rather than to try to do it. You should make sure you take out the entire surface here, and mostly these patients are going in for an ART later on. Then, so you have to take care about the cornua and make sure that there is no spillage there. This is way, just like how you mow the lawn, you just take the entire strips one by one there. And here you have to be very, very careful that there is no myometrial invasion before you plan for that. The reported pregnancy rate of this is as high as about 65% in the 50 months follow-up there. We have to be very careful. The endometrial carcinoma is only a surgical staging when you do the entire surgery. But however, we preserve the ovaries here for fertility option there. So when we preserve the ovaries, there is an increased risk of ovarian neoplasm, risk of synchronous ovarian cancer and metastatic endometrial cancer to the endometrium should be considered in this patient when you are preserving it there. Then what about the surveillance there? We have to repeat the endometrial sampling with the fertility preservation approach in order to assess the response to the therapy, assess for the progression or recurrence of the disease there. There is no consciousness to the method of sampling. PIPL, or ideally the PIPL has been used. Sampling is done every 3 to 6 months. And then in case if you have a suggestion or a suspicion, then you have to perform a DNC. Obesity and weight loss management, definitely the investigator have found out that it is a very useful for conservative treatment there. Attention on weight management is very important for all overweight and obese patients undergoing treatment for endometrial cancer there. And it has been demonstrated that weight loss can decrease the recurrence rate. So if your patient is obese, where you are just giving a fertility preservation, you should mention about the weight loss program and make sure they follow it up there. We have been highlighted on the molecular characteristics and potential implications on the treatment there. So if you have a pole thing, then pole definitely it is a good prognosis where you can preserve. If you do a mismatch repair stability proteins, which can be done from a PIPL or from a DNC or from a hysteroscopic scraping, and it is a guarded prognosis where you have to be very careful in counseling the patient for fertility preservation there. What are the fertility preservation options here? One, they can spontaneously conceive or they can come for assisted reproduction. So in assisted reproduction, they can come for a oocyte cryopreservation, embryo cryopreservation, in vitro maturation, and gestational surrogacy. So if the patient has got a good ovarian reserve, if there is a complete cure of your disease, then if there is an ovarian reserve is quite good, then they can just give them some time for a spontaneous conception. But you cannot endlessly wait for years together for a spontaneous conception, because our time frame is short. Soon after they conceive and deliver, we are going to go for a curative surgery. So we cannot prolong much, say about 3 months, following with 3 months of IUI, and then probably you can take them for assisted reproduction. If they don't have a partner, or if they are unmarried, and if they are post-pubertal age group, then you can go in for oocyte cryopreservation. If they are post-pubertal, if they have a partner, then you can just, gold standard is only an embryo preservation. After the complete treatment, you give a wash-off period of about 3 to 6 months, and then slowly go for a natural cycle frozen embryo transfer, with which you will be able to achieve a pregnancy without increasing a risk for the patient. And in case if there is no time for the ovarian stimulation, where then you can just go in for in vitro maturation there. In all cases here, when you are stimulating the patient, you have to avoid supraphysiological levels of estrogen. How do we do that? We start them on letrozole from day 2 to till the trigger. During this period, it reduces the estrogen level. However, it doesn't alter the oocyte quality. Finally, we have the option of gestational surrogacy. As I mentioned it, for various things, there is a level with which we have to go, and the stimulation should not affect the supraphysiological levels of estrogen there. To conclude, fertility sparing approach for grade 1 endometrial carcinoma is limited to the endometrium and is feasible, and it can be considered in the reproductive age group women plan to conceive in the near future. Treatment should be individualized rather than one size fits all. Approach should be given, as I mentioned, on various aspects, balancing the oncological safety and the individual patient goals. Patients should undergo extensive counseling about the risk, benefits, and alternatives of conservative approach, with the understanding the currently available data are largely of retrospective case studies with a range of treatment regimens and doses there. So future prospective studies are needed to determine the optimal treatment regime for this reproductive age group women with the fertility, the endometrial cancer. Thank you very much for your patient listening.
Thank you, Dr. Gopinath, for such a wonderful, in-depth lecture in a very nutshell than the indication who are all the candidates for the fertility preservation, and you insisted on the pre-operative evaluation. And if there is no hysteroscopic availability, DNC will be a better option, and invasive things should be assessed by MRI. And the options, the different options you have talked about, hormonal and LNG, and when to do an embryo preservation, when to do an oocyte reservation, and in vitro, so many things you have dealt in depth, and how to do the surveillance of such patient. Thank you so much for the wonderful in-depth lecture. Thank you so much.
Thank you.
Good evening.
Yes,
Happy to. Good evening.
Yes, ma'am. Please introduce next speaker.
You're audible, Dr. Geeta.
Yes, madam.
Introduce him.
Very happy to introduce Dr. Rajiv Rajendranath, a senior consultant of medical oncologist at Integrated Cancer Group, Chennai. Sir is a DM in medical oncology. He had done it in Adyar 2007. He was also a professor and teaching faculty at Cancer Institute, Adyar till 2015. He has special interest in breast and gynec-oncology, gastrointestinal and genitourinary oncology, and also geriatric. He has been awarded in 2013 with the K.S. Sanjeevi Award for Outstanding Contribution to Poor and the Needy. He has been also awarded the Best Doctor Award at Tamil Nadu MGR Medical University in 2011. And he's also an honorary consultant medical oncologist at Southern Railway Headquarters. Happy, sir. Kindly, he is going to talk on tumor test and targeted therapy.
Thank you so much, Madam Chairperson. And I also thank all at Oxy and Dr. Deepa for giving me this opportunity. So the topic I am given is tumor testing and targeted therapy in endometrial cancers. Most of the previous speakers have dealt with part of my talk, and that has made my job easier. So we will look at the relevance of tumor testing in general. So if you, instead of one size fit all, now we molecularly profile most of the cancers like lung cancer and breast cancer, and now also in endometrial cancer. Basically, it will help us prognosticate. As Sir was mentioning in his previous talk, even in fertility preservation, if you have a pole hypermutated tumor, then we are very sure about the excellent prognosis in such tumor that we can do de-escalate treatment and even keep them the fertility preservation option. So that can happen only with a molecular profiling rather than the conventional pathological prognostic markers. Also, this helps us in understand or predict the response of a drug which is going to be sensitive or resistance. So the concept of targeted therapy is such that we need to identify specific molecular targets. For example, the pathology talk, it mentioned that HER2 testing. So HER2 new testing, we regularly do it in breast cancer, and in high-grade serous endometrial cancer, we do the HER2 new testing, and that has opened up targeted therapy of anti-HER2 new therapy even in uterine cancers like drugs like trastuzumab. So it helps us in predicting the response to targeted therapy, and sometimes it can also tell us which are the drugs which we can avoid by using the markers predictive of adverse events. So this is the era of personalized medicine in oncology, and endometrial cancer is also no exception, and we will see how it is done in the tumor and how we can select the targeted therapy. So this was mentioned earlier. This is the conventional approach. We risk stratify based on the stage, grade, and type of tumor, and we usually observe low-risk patients without adjuvant radiation or chemotherapy. And in intermediate risk, majority of the patients, if they are stage 1B, G2 or a 1A, G3, we get away with only vaginal brachytherapy. Whereas if it is any of the high-risk patient that is at anything above 1B, G3 or stage 2 or stage 3, we go all out and give pelvic radiotherapy as well as chemotherapy in majority of the patients, because we know that they have a chance of locoregional as well as high chance of systemic recurrence. Now we come to how we test the molecularly using the Cancer Genome Atlas molecular classification, which again has been dealt with the pathology talk. So the basic spectrum of tumors then is mainly to divide them into a pole hypermutated tumor, which has the highly mutated tumor and they have excellent prognosis. But the issue is most of the studies have shown that they are only in 7 to 8% of the total endometrial cancer type. So though very rare, if somebody has pole hypermutated tumor, we can look at very good prognosis and de-escalate majority of the treatment. If you have a MSI testing, so the basic idea is to do initially a screening immunohistochemistry by using MMR, that is look at the deficient proteins. And if you have a loss of MSI, the PMS2 or MLH1, then we know that there is a high probability of that tumor being MMR, and if you have a high chance of microsatellite instability, then they are basically hypermutated tumor, and they are reasonably good prognosis, and some of them may be part of the Lynch, which we will look at by doing genetic testing or germline testing, and also it also predicts very high response to immunotherapy. So it is a prognostic as well as a predictive marker. Anything which is MSS or P53 mutation, they have intermediate or high risk prognosis, and they need to be treated more aggressively, and their outcomes are not very good. So this is the general way we look at it. So you have the TCGA subtype, the pole, the MSI hypermutated, MSS stable, and the copy number high serous like. So if you have a high grade serous endometrioid carcinoma, we usually ask our pathology colleagues to routinely do HER2/neu IHC study, and if needed, FISH testing also, because there is a high chance of 30 to 40% of it being HER2/neu positive. And we know that if they are HER2/neu positive, then we can use targeted therapy like anti-HER2/neu therapy like trastuzumab and other drugs in the metastatic setting. There is also other lesser common mutations like FGFR amplification or mutation and beta-catenin expressions that can be picked up by doing tumor molecular testing. It is of interest to know that we have drugs being developed. So we have targeted drugs now available for FGFR amplification, though as of now not available in India. So it's a very exciting scene as far as endometrial cancer molecular profiling is concerned. Now, the common questions the postgraduates and the junior colleagues ask is, if you don't have the resources to do the entire molecular profiling and the cost involved, then also we can generally get away with 2 IHC testing. So we know that, as I told, pole mutation is very uncommon. So we can actually, it will be only single digit. So we can leave aside the NGS testing and just do IHC for P53 and also MMR, that is mismatch repair protein IHC panel. So if you have a P53 mutation, then we know that that is an unfavorable prognosis. And if you have MMR deficient, then we know that it is a MSI high. Rest all can be classified as non-specific, no specific molecular profile, and we treat them in conservative. So the advice would be to at least do P53 IHC and MMR testing by IHC at least in all of our patients, so that we can prognosticate and predict the treatment options well. Now, when we look at the prognostic significance, as I told that if you had looked at a grade 3, usually what comes to our mind is they don't do usually well. But then if you can look at the pole mutation who is grade 3, you can see nearly 100% survival. So what it means is the conventional thing that grade 3 is poor prognosis is true only in a subset of molecular profiling, like if they are P53 mutated. Or if you look at patients who are otherwise good prognosis by conventional, and if you have a P53 mutation, then they may not do well as expected. So these are complementary. The conventional testing obviously should be done, but this molecular testing helps us in prognosticating and predicting our treatment better. And that's why even the WHO has accepted in that the classification and integrated diagnosis of using the molecular testing and making a classification based on molecular classification. And the recent, if you look at the European Society of Gynec-Oncology guideline, slowly they are coming into the treatment options also. So if you have a molecular classification known, and let us say, as I told, the most common pole mutation, if it happens, the most favorable pole mutation, then even if you have a stage 2 disease, where conventionally we would have given chemotherapy and sometimes whole pelvic radiation, you can avoid by giving no treatment as an option. Though we don't have large data for all this, but these are coming up very well. So the integration of molecular markers in classification as well as in practice is very much there, because we can risk stratify them better, and it actually can integrate into the conventional markers like LVSI and and other molecular markers, so that we can decide on the treatment with more accuracy. So coming to the mismatch repair deficiency, as the pathology talk it told, we can do it by 4 IHC panel testing. So it is as high as 30% of endometrial cancers, and most common combination is by MLH1 promoter hypermethylation, which is shown by Madam had shown in her slides, MLH1 and PMS2 loss. So this IHC can be taken as a screening test. So if you have this combination of MLH1 PMS2 loss, then we can go ahead and do the germline testing to do the to assess the need for Lynch syndrome diagnosis. That is by double somatic event. Basically, they are hypermutated cancer, and when you have a hypermutated cancer, that is a nice tumor microenvironment for our drugs like immunotherapy to work well, because the DNA repair defects results in abundance of neoantigen, and this results in strong host immune response. So if you have a PDL1 binds to PD1 on T cells, that is the one which is suppressing the immunological response. So we have drugs like this PDL1 inhibitor and PD1 inhibitors available with us, like pembrolizumab and nivolumab. Once we give those drugs, the checkpoint inhibition activates the response. And is it clinically relevant? Yes, very much. So if you could identify a MMR deficient tumor and you start giving these agents even in a stage 4 endometrial cancer, where with conventional chemotherapy, we know that the outcome is not very good and the intent is very much palliative. Here you can see that the response rate will be 50%, with 12% of the patients going into a complete remission and some of them going on to become long-term survivors. These are unheard of in metastatic endometrial cancer, otherwise in general. So this has been validated in the PORTEX studies. So the postgraduates will know that the PORTEX study is the one which looks at the adjuvant radiotherapy and chemotherapy. So in those subset of patients, they've looked at these molecular subgroups and all the hotspot mutation like BRAF, CTNN, B1, and the protein expression like L1CAM. And they have sort of concluded that if you have this P53 mutation, they didn't do well, and POL mutation, irrespective of what you have treated with radiotherapy or without radiotherapy, their survival is excellent. So this is how the PORTEC-3 trial looked like when they molecularly classified them retrospectively. And again, you can see that the survival very much dips when they are P53 mutation, and the non-specific molecular profile is somewhere in between compared to the hypermutated tumor. So this is again an example where your POL mutation survival is excellent in the PORTEC-3, whereas when you have a P53 abnormality, your survival goes down even after giving chemotherapy and radiotherapy. So the role of the submolecular subgroups with or without adjuvant treatment also has been looked at, but these are not retrospective series, but they found that with nodal staging and lymphadenectomy and with and without adjuvant treatment, you can see that with adjuvant treatment, some of the importance can be the improvement in survival, but in majority of the patients who are hypermutated, irrespective of your treatment, they do very well. So this will help us in designing the trial in much more accuracy, like in the PORTEC-4 trial, which is very interesting, where the first trial to investigate molecular based versus standard adjuvant treatment. So here they molecularly profile all the tumors and then come to the conclusion whether they are favorable, intermediate, or unfavorable based on the molecular tissue profile. And then they start designing the treatment. So if you have a favorable treatment arm, then they go in for observation. Whereas if they are intermediate by molecular, then they do vaginal brachytherapy. And if they are unfavorable only, they will give external beam radiotherapy. Whereas all these patients would have received brachytherapy based on the conventional risk factors. So this trial will tell us how molecular classification will help us in deciding the treatment in the very much future. And this trial is almost accrual is completed. Hopefully in the next 1 or 2 years, we'll have the results being read out, and it will definitely change practice. So this is all possible because of the testing called next generation sequencing. Usually it is a somatic testing. That means it's a tissue testing. It uses a commercial panel for mutation in multiple genes, and it is helps us in deciding the treatment option. So the basic technology is you select out the sample, you pick up the DNA, and then you construct the shotgun library, that is DNA fragments. Then you hybridize it, and then the DNA is captured and sequenced with high-end software, so that you finally get the readout of the alignment of the different and the mutations that are available. So this is called the genome sequencing. And we can have next generation sequencing hotspot panels. That means if you are interested only in particular genes like EGFR gene or HER2 new gene, you can do hotspot testing so that the readout will be faster. But in some places like in a metastatic cancer, you want to know all the possible treatment option, then you can go for a comprehensive genomic profiling where the entire genome is sequenced either by RNA sequencing or DNA sequencing. And finally, we get a readout on what are the abnormalities and what are the possible targets for a particular patient, and are there any drugs available for the target. So these were all very much hi-fi a few years back. Now we very much use it in practice in many other sites, and definitely in endometrial cancer in the near future. So the different types of sequencing for postgraduates, they are whole genome sequencing, whole exome sequencing, and the targeted sequencing. The whole exome sequencing is the most comprehensive one, and you can get thousands of genes being evaluated at the same time. And earlier it was very expensive, but now many of the Indian labs do it under reasonable rates. So from there, we find out whether the mutations are non-heritable, that is somatic mutation, or the germline mutations. Then if there is a germline, for example, BRCA mutation detected, then you have to test the siblings and the children as per the guidelines. Mismatch repair testing is done by, as I told, looking for mutation in 4 genes, that is MLH1, MSH6, and MSH2 and PMS2. And we usually do it in endometrial cancer, and we also look at how we can look at germline testing for Lynch syndrome. So BRCA testing is one which are recommended mainly for breast and ovarian cancer, and sometimes if you have high risk family history for endometrial cancer. And this is one of the commercially available comprehensive genomic profiling platform available for us to do this. So how do we bring all this into clinic? So there are a lot of adjuvant treatment based on the molecular characteristics which are available. You can target HER2 new. There are PARP inhibition that are available. And there are a lot of trials looking at immunotherapy in the adjuvant settings. As of now, they are not standard, but we are sure that it will come up in the future. So this is a dream trial which is happening. It's called the Rainbow trial. Here you refine the adjuvant treatment in endometrial cancer based on the molecular features. So if you have a P53 abnormality, you go ahead and give chemoradiotherapy and olaparib. If you are giving MMR deficient, then you de-escalate, don't give chemotherapy, give immunotherapy and radiation therapy. And if you are POL mutation, don't give any treatment. So this is the prospective trial. We are all hoping it will come positive, and which will help us in deciding treatment more accurately for our patients. So we are almost getting there. We have so many targets which can be used, and so many molecules which are already sort of approved in other indications, and in endometrial cancer trials are ongoing. So is it all useful? Finally, they will ask, is it all fiction or is it used in our clinical practice? Luckily, I had a patient 2 days back where we have done in an endometrial cancer who had metastasized after 10 years. And we did a MMR testing, and you can see that there is loss of nuclear MLH1 and PMS2, and this shows that she is MMR deficient. And we have offered her immunotherapy and hoping that we will have a good results in her. And these are labs which do the endometrial cancer prognostication panel, as sir was suggesting. If you're looking for fertility preservation, you want to know pole mutation, it can get commercially done in India with a turnaround time of 2 or 3 weeks. So summarizing, molecular subtypes of endometrial cancer has become clinically distinct, and hopefully the comprehensive genomic profiling and tissue testing based targeted therapy shall be the future options in gynecological cancers, in endometrial cancer, and we will be hopefully treating our patients more accurately than we do now. Thank you. Thank you so much for the opportunity.
Thank you, Dr. Rajiv. That was an excellent presentations and lots of new things. I think general gynecologist will be benefit and
Thank you.
really. And Dr. Mangalagita, madam, do you have anything?
Yes. Yes, thank you, sir. It was such a detailed explanation you gave. And how about the importance of molecular testing on drug sensitivity uses, and even about next generation sequencing. It was very useful for us. Thank you so much, sir.
Next speaker may invite Dr. Madhupriya. She is a consultant surgical oncologist from the Integrated Cancer Care Group, Chennai. She is a specialist in breast gynec oncology as well as uro-oncologist. Dr. Madhupriya will be talking to us about genetic testing in the setting of endometrial cancer. Over to you, Dr. Madhu. Sagiti, Dr. Madhu's presentation, please.
Okay, ma'am.
Good evening all, and thank you for this opportunity. So today I'll be talking about the genetic testing in the setting of endometrial cancer. So hereditary endometrial cancer, it makes up to around 2 to 5% of all the cases of endometrial cancers. And among that, Lynch and Cowden syndrome are the two most commonly inherited syndromes, which has shown to increase the women's lifetime risk of endometrial cancer. And there are also non-gynecological malignancies which are associated with these syndromes. So what are the hallmarks of hereditary cancers? That is, when do we suspect hereditary cancers? When the patient has a cancer which has an early age of onset and multiple affected family members, or if there is any presence of multiple or bilateral primary cancers. So moving on to Lynch syndrome, it's also known as HNPCC, hereditary non-polyposis colonic malignancy. It's an autosomal dominant genetic disorder. It increases a woman's lifetime risk of endometrial cancer between 17 to 60%. And as already said, it is a germline mutation in a specific DNA mismatch repair. Other cancers which commonly involved in Lynch syndrome are your colonic, ovarian, pancreatic, stomach, ureter, and renal pelvis tumor. Endometrial tumors from Lynch syndrome patients are usually poorly differentiated, tend to have a tumor infiltrating lymphocytes, and more likely to tend to involve the lower uterine segment. So there are various criteria which helps us to stick on to this Lynch syndrome. Among those are these, like at least 3 or more relatives must have a cancer associated with Lynch syndrome. That could be like your colorectal, endometrial, ureter, small bowel, or any other renal pelvis tumor. And one affected patient is a first degree relative of the other two, or you can have a 2 or more successive generations if it is affected. Cancer in 1 or more affected relatives is diagnosed diagnosed before the age of 50 years. And before coming on to the criteria of Lynch syndrome, familial adenomatous polyp is to be excluded. And you have this revised Bethesda criteria, which more likely fits to colorectal cancers. So if you have a patient who is diagnosed with colorectal cancer before the age of 50 years, and if there is any presence of synchronous or metachronous colorectal or other HNPC related cancers, or if you have a patient who has a colorectal cancers with high MSI diagnosed before the age of 60, or in a patients with one or more first degree relatives with colorectal or any other HNPCC related cancer which has been diagnosed before the age of 50 years, or colorectal patients with two or more relative patients with CRC or other HNP related of any age. So these two criteria helps us to narrow down to a Lynch syndrome. And next slide, please. So how do we come on to diagnosis of a Lynch syndrome? So before we send any patient to a genetic testing, it is always better to have a genetic counseling done by a counselor. So the patient should be referred to genetic counseling with the patient along with the family members should know the implications of genetic testing and what do they expect from genetic testing and how do you have to go about if they have any genetic mutations seen in their testing. So to come down to a Lynch syndrome diagnosis, first you have to do an immunohistochemistry analysis for MMR proteins. And if they are MMR deficiency, and you have to see at the age of diagnosis and family history and go for a genetic counseling and then followed by a germline DNA testing, which if it confirms gives you a Lynch syndrome diagnosis. Next slide, please. So NCCN guidelines cancers risk in Lynch syndrome. So as we can see, the first is colorectal, which is average age of presentation is in 44 years and the cumulative risk is around 46 to 61%. And endometrial cancers average age is around 49 and it is seen in 34 to 54% of the patients. Next slide. So what are the risk management once you have been diagnosed with Lynch syndrome? You can offer the patient about prophylactic hysterectomy with bilateral salpingo-oophorectomy as a risk reduction surgery if the patient has completed childbearing, and educate patients that dysfunctional uterine bleeding warrants evaluation. There is no clear evidence to support screening for endometrial cancer. However, an annual office endometrial sampling is an option. And there is no data to routinely support ovarian cancer screening. However, clinicians may find it helpful in certain circumstances. Transvaginal ultrasound and is like for endometrial and ovarian cancer has not shown to be sufficiently sensitive or specific to support, but it can be considered. Next slide, please. So what are the risks of other cancers and how do you screen them? For colorectal, you can start the colonoscopy at the age of 20 to 25 years or 2 to 5 years prior to the early onset of colonic cancers. There is no clear evidence to support screening for gastric, duodenal or small bowel malignancies. And for considering an annual urine analysis starting 25 to 30 years of age due to risk of urothelial cancers, and annual physical or neurological examination starting at the age of 25 to 30 due to risk of central and nervous system cancers. Despite increased risk of patients, there are no screening recommendation for pancreatic cancer. There is no screening recommendation exists as such. Next slide. So moving on to Cowden syndrome, which is the next most commonest inherited genetic disorder. Like you have, it is caused by autosomal dominant, and it is associated with germline mutation of PTEN. And lifetime risk of developing endometrial cancer is between 19 to 28%. Women have a high risk of developing breast cancer with a cumulative risk between 81 to 85%. They're more likely to be characterized with hematoma, macrocephaly, and mucocutaneous lesions. There is increased lifetime risk of malignancy, including breast, endometrial, thyroid, renal, brain, and colorectal cancers. So this is a cumulative lifetime risk of Cowden syndrome. Like breast, it has around 81 to 85%, endometrium around 19 to 28%. Next slide, please. So how do you come to criteria to diagnose Cowden's? It's divided into major criteria and minor criteria. And some of the major criteria are if the patient has any relative who has breast cancer, endometrium, thyroid, or GIT hematomas or multiple mucocutaneous lesions. These all falls under the major criteria. And these are some of the minor criteria like autism, colonic cancers, at least 3 esophageal acanthosis, and at least 3 lipomas, mental retardation, RCC, and testicular lipomatosis. Next slide. So criteria to refer patient for genetic testing in case of Cowden's is an individual from a family with a known fetal mutation or any patients who meets the criteria for Cowden syndrome as above. And at-risk individuals with first-degree relatives, individual with a personal history of any one of the following, like autism, adult Lehmann-Metz Duclos disease, 2 or more biopsy-proven trichomonas, 2 or more major criteria, 3 or more major criteria without macrocephaly, 1 major and at least 3 minor criteria. So all these patients can be referred to genetic testing for Cowden's syndrome. Next, please. So how do you manage when Cowden's disease, Cowden syndrome is diagnosed? Like you can, for uterine and breast cancer, you can educate the patients regarding symptoms of endometrial cancer and encourage prompt notification. Consider annual random endometrial biopsies and or ultrasound beginning at the age of 30 to 35. You can also discuss risk reducing mastectomy and hysterectomy, counsel regarding degree of protection and any reconstruction options for post-mastectomy. Oophorectomy is not usually indicated and breast awareness should be started at the age of 18. Clinical breast examination every 6 to 12 months starting at the age of 25 or 5 to 10 years before the earliest known cancer in the family. Annual mammogram and breast MRI screening starting at the age of 30 to 35. For reproductive age women, advice about prenatal diagnosis and assisted reproduction, including pre-implantation for genetic diagnosis. Next one. So for other cancers, you can annual comprehensive physical examination starting at the age of 18 or 5 years before the younger diagnosis. Annual thyroid ultrasound scan starting at the age of 18 or 5 to 10 years before the earliest onset. Colonoscopy can be recommended starting at the age of 35 or again 5 years earlier to that of the primary patients. And you can consider renal ultrasound starting at the age of 40, then every 1 to 2 years. Dermatological management may be indicated for the patients. And next. So as I said earlier, before we send any patients for the genetic counseling, they have to understand the benefit of genetic testing. You can end up in having an uncertainty, clarify cancer risk for an individual, and you have to clarify cancer risk for relatives, aid in medical decision making, and it may relieve anxiety for after doing a genetic testing. Next slide. Whereas the risk and limitations, negative test results may be uninformative or falsely reassuring. Patient may prefer not to know their genetic status or future cancer risk. Time of testing may not be optimal. Concerns about just genetic discrimination may be the common problem which the normal patients faces. Next slide. Thank you.
Thanks, Dr. Madhu.
Yeah, thank you, ma'am.
Mangalagita, madam, anything? See, there
Yeah,
are.
and thank you, Dr. Madhu. It was so detailed explanation on how hereditary and how it should be screened and importance. Thank you, Dr. Madhu.
Okay. There are lots of questions in the chat box and also one question in the QAA. Question answer session. So anyone from the speakers, if they are here, please answer this question. Is there a role for HRT in young age women who have undergone surgical staging and have complete remission? Dr. Rajiv, is there a role for HRT hormone replacement in young age women?
So that's a bit controversial area because we cannot take a simple single assessment for all patients. Young age means we should look at the hereditary component. So as Dr. Madhu was suggesting, if she has come into the Lynch or HNPCC or BRCA related, then definitely she is at risk for breast cancers and other hormone dependent cancers. So their HRT is usually withheld. So that said, if there are no other risk factors and we have a prolonged remission, that is 3 to 5 years of remission, then on an individual basis we can discuss and decide. But there is no one answer for HRT replacement in general. Especially if you have an endometrial cancer at young age, we need to look at the hereditary component before we commit to it.
Kundavi madam asked questions to Dr. Gopinath sir. His sir is there? Gopinath sir?
Go ahead.
Okay, so if ET thickness does not improve following progesterone therapy in fertility preservation, how to go about?
No, this is on the other contrary. So there is a hypoestrogenism or there is an impeding. Here, normally the transfer is done only on the natural cycle. We do not go in for an ERT cycle. It is preferred not to do an ERT cycle. In that case, you can use the sildenafil and aspirin and then see whether you are able to produce a good subendometrial blood flow with which there will be an increase in thickness. Go by the normal LH level and then you can transfer it. That is option 1. If it doesn't fail, then you have to use a minimal estrogen priming to make sure that you get a good blood flow, and then you can just go ahead. The more important in this cases is only the blood flow rather than the entire thickness.
Okay, sir. So in case of mucosal of appendix, should we remove the tube and ovary prophylactically? Dr. Madhu?
It's not routinely practiced, ma'am.
Okay.
The other way around, when we have a mucinous carcinoma of ovary, in that case, sometimes we do the appendectomy to make sure that it is just only from the ovary and tubes, but not from the appendix. So at that time, we either grossly examine the appendix to see if it is normal, or if we find any abnormality, we go ahead and proceed and do the appendectomy for that.
Okay. So out of topic question to Dr. Gopinath sir. So is there a borderline serous cystoadenoma of the ovary? When can we plan? She can plan fertility treatment. How to follow it up? Borderline.
Yeah, the borderline tumors, you can go ahead and then plan for the pregnancy, because later on subject, you are going to give a complete curative treatment. You are not going to leave it long. So in that scenario, without a very severe and very high estrogen production, then you can stimulate them to a certain extent. It is not a contraindication to induce ovulation in a borderline serous cystoadenoma of the ovary.
Thank you, sir. And one more questions again from ovary. We have 8 years old child with mixed germ cell tumor, which is 80% comprises of yolk sac and 10% of choriocarcinoma. What can be done for her? She's just 8 years old.
Yeah. So here, there is absolutely no place for ovarian tissue cryopreservation. See, the only option here is ovarian tissue cryopreservation because patient is pre-pubertal. So if in a case of where you have suspicion on a mixed germ cell tumor and 10% choriocarcinoma, you have no compromise. You cannot do the OTC in this particular patient. So your options are limited.
Thank you, sir. So
ma'am, can I add?
Yeah, please, Rajesh.
Yes.
So if from the medical oncology point of view, if I hope it is a unilateral tumor, because usually mixed germ cell tumors are unilateral. Usually we give chemotherapy upfront. So it's a very, very highly chemosensitive tumors. And in pediatric ovarian germ cell tumor, there are data to use carboplatin instead of cisplatin. So if you give chemotherapy, majority of the time we can get away with the unilateral self-oophorectomy, and usually the staging will sort of fertility preserving surgery itself we can do by preserving the contralateral ovary and the uterus. But if the problem happens if it is a bilateral tumor, bilateral ovarian germ cell tumor, and that usually happens in dysgerminoma. And if that is the case, then we may not be able to preserve the ovary, but we can still preserve the uterus for future options. But it is unlike epithelial ovarian cancer, we need not be very aggressive in staging in ovarian germ cell tumor, especially in pediatrics, because it's highly chemosensitive.
Thank you. Thank you so much, Dr. Rajiv. Any more questions? Dana, madam?
The first oncology committee meeting went on very well. So I'm very, very happy for it. Thanks to Deepa Tangamani for selecting appropriate persons for the and selecting apt topics for this first ever oncology committee meeting. And thank you, Deepa, first of all, and thanks our President Madam and Secretary Madam for allowing us to conduct this. And thanks to all the speakers who put their heart and soul into the preparation of the slides. And I know all of them, it looks like we could have given them some extra time to, they deal with it much more at a leisure way. But time constraint is a major issue in most of these webinars. And I thank the delegates who have joined in large numbers. And I thank Shield Chitrakala for giving us this platform. This is Sahiti or Chitrakala? Sahiti.
Sagiti. Today Sagiti is with us. Okay. Thank you, madam. The main purpose of this masterclass series, we'll do next sessions on breast, ovaries, cervical cancers as well as. So this is to highlight the importance and the what happens post-operatively after the post-operative care. Once you diagnose the cancers, what will happen? So we cannot just do the surgery and we leave. We just have to know the extent of how the pathology report is, how to read the pathology report, what to do after pathology report, whom to we direct properly. And second thing that post-graduation who are doing an obstetric gynecology, then they can continue go through this kind of webinars, masterclass series on the cancers, just so that they can aware about the oncology fellowships. So hope many will do as the course ends, many will take up the branches of fellowship in gynae oncology. Thank you, speakers. Thanks. At the outset, I would like to thank Jairani madam as well as Kundavi madam for giving this opportunity, and Dana madam, just give me a free hand to coordinate with the speakers. Thank you so much, madam. Thank you, speakers. Thank you, chairpersons, our dear chairpersons.
Thank you, Deepa. Thank you, Dana madam.
Okay.
Thanks for smoothly conducting the sessions. Thanks.
Thank you. So leave the session, please.
you, ma'am.
All the speakers as well as chairpersons stay on the group.